Good evening, everyone, and welcome to today's MedTalk Digital CME session. I am Adafshin, your moderator for this program. Today's session highlights an important and often overlooked clinical challenge, pituitary incidentalomas, what every clinical must know. With advances in imaging, incidental findings in the pituitary glands are being reported more frequently, making it crucial for clinicians and distinguish benign cases from those requiring intervention. It is my honor to introduce our speaker, Professor Dr. Arpan Dev Bhattacharya, sir. Let me share some of his achievements. He did MD in General Medicine. He did DM in Endocrinology. He did DNB in Medicine, MRCP, CCST in Internal Medicine Endocrinology, FRCP. He is consultant endocrinologist at Manipal Hospital in Bangalore. He is professor of endocrinology at JJM Medical College. With decades of experience in endocrinology and academic leadership, Sir has contributed immensely to advancing clinical practice and guiding young clinicians in the field. So, we are privileged to have you with us today. We look forward to your expert insights on how to approach pituitary incidentalomas in clinical practice. So, the stage is now yours.
Okay, thanks very much. Thank you. Good evening. Um, just to remind you people who are listening now, there is a bit of a problem with the video connection. This Airtel is down in our area, so I have switched off my video. So you will be listening to audio while we'll interact after my finish around 20 minutes or so. I'll switch on the video. So, pituitary incident trauma, I expect to finish around 20-22 minutes. This is just an overview for all of us clinicians. So, whenever you encounter such a patient, what is the next step you need to do? So, learning objectives for today's session is to understand the definition and epidemiology of pituitary incidentaloma. Number two, to understand the appropriate endocrine workup and imaging. And number three, to apply the individualized patient-centered management strategy. So pituitary incidentoma is a previously unsuspected pituitary lesion that is discovered on an imaging study performed for an unrelated reason. We will come to the unrelated reasons why you have done it, but this is important in each and every coining of the words that we are getting a pituitary swelling diagnosed by imaging, whichever it is, CT scan or MR scan, for reason is not done for pituitary. So by definition, this imaging is not done for symptom for specific to this. Now, for example, if somebody had a headache or a stroke or a TIA, spine disorder, and so on, get a scan done, they find a swelling in the pituitary gland, whatever the size, microadenoma or microadenoma, then what are the things that we need to do? So now, this is a big series that why the imaging were done. You see, the main chunk is neurological and other clinical symptoms, starting from headache to visual symptom to cranial nerve palsy to sinusitis, otitis, tinnitus, neck pain, mastocytitis, SIADH, syncope, fatigue, and so on, and workup for dementia or some injury, whether it is a or illness like a CVA, TIA, trauma, Parkinson, cervical spine disease. Some other thing, some people doing a dental check and then getting a scan done, that can happen as well. But essentially important to remember that this imaging is not done for the pituitary gland, and that is the reason it's called incidentaloma. So incidental detection of a oma means a tumor. Now, when you see a pituitary incidentaloma, what are the things that's possible? Look at from the other side. So we are not talking about differential diagnosis of pituitary mass. We are talking about when you have detected somebody with a pituitary incidentaloma, what are the normal series tells that. So it can be pituitary adenoma or a hyperplasia or a metastasis, carcinoma. It can be carotid aneurysm, intracavernous aneurysm, or cavernous arteriovenous malformation. It can be a cleft cyst, arachnoid cyst, epidermoid cyst. It can be hypophysitis. That is a very important diagnosis now we are encountering. It's called lymphocytic hypophysitis. Or it can be some dermatomatous disorder. It can be meningioma, craniopharyngioma, lymphoma, myeloma, pituitoma, infiltrative disorder like sarcoid, amyloid. It can be empty cella. Now we are talking about incidentaloma. We are talking about empty cella because the part of that swelling may look like that. So essentially, what is the challenge is that when somebody comes across with this type of, say, neurologist has done some test for a CVA and they found a pituitary swelling, and they ask you what need to do. We need to remember these are the could be the possible differential diagnosis. In your picture, you see in your screen, you see an imaging. So this is a sagittal coronal cut side by side, and this is what is the pituitary gland area looks swell. Now I'll put a normal one. See, normally it looks like this black one is the sphenoid sinus. Here in the sphenoid sinus, these are cavernous sinus, carotids. This is the pituitary gland. This is the infundibulum. Okay. And here on the coronal cut, again, this is the sphenoid sinus. This is the pituitary fossa. Normals can look like that. Infundibulum. Here in this photograph, you can see the pituitary gland area is quite a bit swelled. So this is by definition is pituitary swelling. And this person, if the imaging is done for some unrelated reason like a headache or something, then we will tell that yes, this person has a pituitary incidentaloma. If you see the epidemiology, the highest prevalence in autopsy series, okay, autopsy done for adults for any reason, 10%, 1 in 10, which is a big number. So which essentially tells that most of them are non-functioning and basically very innocuous. They are not creating any problem. If you do the MRI based studies for any reason, the MR scan done of the brain, 0.1 to 0.4%. So around 1 in 1000 to 4 in 1000. That's a reasonably good number. The macroadenoma was found around half of them, and rest half of them microadenoma. Definition of macroadenoma, maximum diameter is 10 millimeter or more. So around half and half, 43% or 50% will get the same for you and me. So half of them are macroadenoma, 10 millimeter more. Half of them are microadenoma, less than 10 millimeter. So characteristically, the symptoms risk will be less for the microadenoma simply because they are small, but when the size is big, they can cause some mass effect or hormonal dysfunction. Now, if this swelling is because of pituitary gland tumor, so now the cells which are producing more, they will give a positive symptom because hormonal excretion. But the same gland, when they are pressing the normal pituitary cells, they will give a symptoms of hypopituitarism. And I'm going to go through step by step with each hormone. Important to remember that majority are non-functioning. So they are maybe a mass of a fibroblast or the fatty tissues. They are itself not creating any problem other than the mass effect. And again, this one I'm going to come with the mass effect as a typical of teaching program. I'll go a bit of a basic way how we approach. So this is the way the pituitary gland, and you can read this as pituitary incidentaloma we approach. 3 heading: functional, anatomical or structural, and etiological. So functional, we need to see the each and every hormone that comes to the pituitary gland, they are overactive or underactive. In the anatomical, we want to see just the swelling, whether they are giving any problem to the surrounding structure. Again, what are the surrounding structure? I will come to that. And etiological, whether any particular they're infective or the tumor. If the tumor there's a malignant or non-benign, that's where we'll approach. Let's start with the functional. Most of the time I'll spend on the functional aspect, whether hyper or hypofunction. So anterior pituitary gland gives us 6 hormones: growth hormone, prolactin, ACTH, TSH, LH, and FSH. And posterior pituitary gland are called neurohypophysis, vasopressin, and oxytocin. Now, normal homeostasis will be like this. I have just put in the cortisol to just put in the picture. From the hypothalamus, CRH comes, corticotropin releasing hormone. It pituitary gland, it stimulates the corticotropes, which gives ACTH, adrenocorticotropin hormone, which in turns stimulate the adrenal gland to give cortisol. And this cortisol has a negative feedback both at the level of pituitary and at the level of hypothalamus. So most of the hormones will go in that. In place of adrenal gland, you can put the thyroid gland. So it will be in place of CRH, it will be TRH. In place of ACTH, it will be TSH. In place of cortisol, it will be T3 or T4 hormone. But basic concept will remain same of our homeostasis. Let's come one by one. First one, let's see growth hormone. Now, if somebody's growth hormone is hyperfunctioning in the childhood, they will develop gigantism. But once your epiphyseal ends are fused, in adult, they will present an acromegaly. Okay, so these clinical features we'll see, and whenever we are talking about the test, we'll do a growth hormone suppression test by glucose, which is called glucose suppression test, and we'll check IGF-1. There are so other tests are there. I'm just trying to make it simple. You will remember one of the principle of endocrinology. If you are investigating overactive condition, you suppress it. If you are investigate an underactive condition, you stimulate it. For example, in the Cushing, you do dexamethasone suppression test, but in Addison's disease, you do a synaptin stimulation, ACTH stimulation test. So this is our GH. Let's come to the prolactin. What they will present? If it's hyperfunction of the prolactin in the childhood, they will present as delayed puberty, and in the girl particularly, they will present a primary amenorrhea. So you have a pituitary incidentaloma, which is basically prolactin secreting tumor. In the childhood, they will present in the boy the delayed puberty, girl is the primary amenorrhea. This is so hypogonadism, secondary or pituitary hypogonadism. In case of adult, there is a man, they will present as secondary hypogonadism and infertility. In women, will present an irregular period, galactorrhea, and infertility. So these are the clinical features we will be inquiring. We are seeing a pituitary incidentaloma for the prolactin function. So test, what we will do, here it is very simple, serum prolactin. There are different ways can be done. Textbook picture will be, you take 3 samples every 90 minutes, so then take the average. You can do pool sample, which means that you take 3 samples and mix them and then test them so that the cost comes down. But end of the day, prolactin, that is the only test to be done. Next hormone, ACTH, adrenocorticotropin hormone. So hyperfunction is Cushing's disease. Okay, Cushing syndrome is adrenal gland hyperfunction. This is a pituitary ACTH mode. That's why adrenal is producing more cortisol. And we know from our MBBS days is a Cushing's disease. And the test we do a dexamethasone suppression test, and also we do ACTH. You can do CRH infusion test, inferior petrosal sinus sampling. Lot of tests are there. We'll not go to those complicated issues. We are making a conceptual understanding of pituitary incidentaloma. If it comes to TSH, it will become TSH secreting pituitary adenoma. Okay, so they will develop more TSH, will stimulate the thyroid gland. Thyroid gland will produce more thyroxine. So hyperthyroidism, because it is centrally driven, we will call it a secondary hyperthyroidism. You remember our normal hyperthyroidism, which you and me see, 95, 98%. T3, T4 is high, but TSH is suppressed because of feedback inhibition. Here, you will see the TSH is not suppressed. Thyroid hormones are high, but the TSH is 5, 10, 15, 20. So it is the diagnosis of secondary hyperthyroidism. We'll check free T4 and not suppressed TSH. Very, very important. Then comes the hypofunction. We are discussing about the functional aspect, hypofunction. Growth hormone hypofunction in the children. it will be short stature. In adult, it will be adult growth hormone deficiency. Other than the growth hormone has a lot of other function. This is what called adult growth hormone deficiency. In the children, for diagnosis of short stature, we do stimulation test like a clonidine stimulation test, insulin stimulation test. We don't do this with insulin. This has not been licensed now because of hypoglycemia related mortality, which has been reported in the children for growth hormone deficiency. In adults, more than the test, we can do clonidine stimulation test. More than the test, we do an AGDA scoring. So it's called Adult Growth Hormone Deficiency Assessment Scoring. And that tells, go ahead, the person has the adult growth hormone deficiency chances there or not. If ACTH is low, cortisol will be low because less stimulation of the adrenal gland. So we'll develop a secondary hypocortisolism. And when you do the blood test, we can do an ITT again with this adult, we can do, not with the children. And we can do CRH infusion test, difficult other than the academic institute. But you'll remember in this typical picture will be your cortisol is low and also ACTH is low. So that means this is a secondary hypocortisolism. LHFSH, gonadotropin. Okay. Hypofunction, if LHFSH is low in the childhood, again, the boy will develop delayed puberty, girls will have primary amenorrhea, typical adolescence age at 12, 13, 14. But in adults, in male, they will present like hyperprolactinemia, erectile dysfunction, less secondary sexual character, infertility. But in women, irregular absent periods and infertility. Here, you will not be seeing galactorrhea because for galactorrhea, prolactin need to be high. And the test usually we do LH-FSH and the target organ, whether it is a testosterone or estradiol. Prolactin, hypofunction prolactin or less prolactin. In the childhood, you will not know. Adult male will not know. But adult female, only time the symptoms will be giving as a lactation failure. Somebody delivered and no feeding, you check prolactin is low. And the test itself is not probably needed because normal and the low prolactin is differentiation is difficult. But obviously, if somebody is a lactation failure, we will always be checking a prolactin just to make sure this is low or lower, very lower side of the normal. TSH, as you understand now, they will develop secondary hypothyroidism. So TSH is low, so T3 and T4 is also low. In the childhood, they will present at short stature. An adult will tell it secondary hypothyroidism and we will be checking a free T4, not TSH. You very remember the monitoring of secondary hypothyroidism we should not be doing at the TSH. You will be doing a free T4. We don't do a free T3, doesn't give an extra advantage. We check in free T4. For example, somebody with a hypopituitarism, we are following the dose of thyroxine. You should not check TSH because this will mislead because TSH will be very low. So wrongly, if the TSH is low, you will reduce the dose of thyroxine, which will be a mistake. So that was our first heading, which is the functional. We have discussed about the hyperfunction. Now let's go to the anatomical, second one. Anatomical means this is a big swelling that is causing a pressure effect on the surrounding structure irrespective of the function. We know that if the pituitary gland goes down, we develop CSF rhinorrhea, sphenoid sinus. If it goes up, it checks the visual pathway. So you'll develop visual field defect or hypothalamic disorder. Laterally, there are cranial nerve 3, 4, 6, 5, 1, cavernous sinus problem. Anteriorly, visual pathway, frontal lobe, brain, and posteriorly doesn't happen because this back of the pituitary, the petrous clevoid bone, that is the petrous temporal bone, which is the hardest bone in the body. The soft tissue swelling or soft tissue tumor cannot erode the hardest bone. So above optic chiasma, hypothalamus, visual defect, hypothalamic symptom. Below sphenoid sinus, CSF rhinorrhea. Lateral cavernous sinus, extracranial nerve involvement, cavernous sinus thrombosis, diplopia, and the front optic chiasma, frontal lobe, visual defect, frontal lobe symptom. So this is a typical of another as a pituitary swelling. This is the sphenoid sinus. This is the pituitary swelling. This is the petrous temporal bone. So anteriorly, visual pathway and the frontal lobe. Superiorly, visual pathway and hypothalamus. Inferiorly, sphenoid sinus, CSF rhinorrhea, meningitis, all this, and laterally cavernous sinus. is the typical of a visual field. These are two eyes. One is the right and one is the left. So the different colors, whether visual field defect or not. So structural assessment of the pituitary swelling or incidentalloma will be a clinical, as I told, up, down, right, left, below, and front, and the visual field. Use this is a manual visual field. Now always do the computerized visual field. The third point comes an etiological. So is it benign or a malignant or an infective or a metastasis, or it is so. The commonest cause, I have initially you have seen the slide, is a benign tumor, benign non-functioning tumor. Other causes remain as metastasis, craniopharyngioma, lymphocytic hypophysitis, pituitary carcinoma, and so on. A quick touch on oxytocin, vasopressin, oxytocin, main effective myometrial contraction. Probably we don't do anything, has some role in milk secretion, but for us important vasopressin. Excess and deficiency is more of a problem. If the vasopressin is excess, it will develop a condition like SIADH, syndrome of inappropriate ADH is a vasopressin, ADH secretion. If it is a deficient, it will produce some like diabetes insipidus. Diabetes insipidus means they will have a polyuria, polydipsia, everything, but the blood sugar will be normal. Okay. Insipidus means tasteless. Diabetes means siphon. So normally we tell diabetes, which you mean that diabetes mellitus. Mellitus means honey, sweet. So it is diabetes insipidus. It's siphon because it is coming water coming out. Insipidus is a tasteless because it is very dilute urine. So coming to whatever we are talking, pituitary incidentaloma, MRI has been done, which are a microadenoma or a macroadenoma. Microadenoma usually non-functioning, nothing to be done, but to make sure it is not growing, every 2 to 3 years, or at least 2 to 3 years time, we do one imaging. If it is a macroadenoma but near to the optic chiasma, we need to repeat the imaging a bit more frequently. But if it is not near the optic chiasma, we leave it to 1 year firstly, after that probably every 3 years. If there is a visual field testing, if there is a problem, suprasellar extension, we need to repeat or take an action. Macroadenoma with and we will be repeating around 6 months to 12 months or 1 to 2 years. Pituitary function testing, as we are telling, at presentation we need to do. If all are normal, controversy is there why really we need or not, but during follow-up we need to remember the clinical picture, particularly in the childhood, about the growth and development, sexual development. If there is symptom, yes, we need again hormonal test. And you remember when you do the hormonal test, a very clear, structurally, conceptually, hyperfunction and hypofunction, picking up each and every hormone. First is the clinical feature, then the biochemical test. Biochemical test means as a resting test plus stimulation or suppression test as it is needed. So I think I'm going to stop there and see what you are, any question or discussion points.
Hi, sir.
So this
Yeah.
is what is happening
You
actually.
can you can off your camera, sir.
Yeah, I think that looks better. Yep.
Okay, sir. Thank you so much, sir, for that enlightening and comprehensive session, sir. We will now take questions, sir. Okay. Sir, I am audible?
Yep. Please.
Okay. With all your permission, I'm going to take question. Okay. So the
Yep.
first question is, what are the most common clinical presentation and incidental findings associated with pituitary incidentalomas?
Most common features are actually hypofunction of the pituitary gland. So that means in an adult, if you are seeing, they will develop the features of hypocortisolism because of less ACTH and hypothyroidism. Also, they will present with a hypogonadism symptom. So usually what happens, this type of people will do a simple baseline test to find the hormone effector there, which line of the hormone is affected. So one we do a TSH free T4, one we do an ACTH cortisol, and one we do LHFSH and testosterone in male, estradiol in female. On top of that, you'll do the prolactin. This is more or less we'll do. In the adult, we don't routinely do the growth hormone dynamics because we expect that will be low, but we only do when there is a chance of treating with a growth hormone once we find the diagnosis. You remember till now the growth hormone has to be given an injection like an insulin everyday injection. Now we have a once in a week growth hormone available, but depends on the particular situation. This is what is the adult scenario. But childhood, it is important to follow the growth, physical growth, the height, and the sexual development.
Okay, sir. Thank you for the answer. Now I'm going to take another question. Okay. So the question is, which investigation, hormonal and radiological, are essential for the initial evaluation of pituitary incidentaloma?
Yes, because by definition is incidentaloma, so you have only detected by an imaging. Otherwise, how we will know there is a swelling of the pituitary gland? So now because the frequent availability, easy availability of the imaging technique, whether CT scan and MR scan done for so many different reasons, starting from the headache and so on, obviously we are picking up a lot more incidentaloma. But good news is that most of them are small and most of them are benign and harmless and not creating any problem. But to make sure that they are not creating a problem, we need a simple and basic workup. That's what is very, very important. That's what our purpose of our today's program and what every clinician should know.
Okay, thank you so much for the answer, sir. And here I can see there is only last question and I'm taking. So the question is, what are the current guidelines for monitoring and managing pituitary incidentalomas, including indications for surgery versus observation?
Right. This is the last slide I was taking. That is sort of a guideline, but guideline will remain guideline unless we understand and try to implement in our practice. So most of the guideline comes from the Western world, may not be completely applicable, all those things. So indication of surgery will be when there are compression feature. For example, you have detected somebody pituitary incidentaloma, you are fine and observing after 1 year that is very bigger and they punctured the sphenoid sinus and developing CSF rhinorrhea. This is the one which needs surgery. You need surgery for debulking of the pituitary lesion and also the repairing the cellular floor so that the CSF does not come in the sphenoid sinus. Similar situation with the visual field defect. You are seeing somebody has a visual field defect. Common visual field defect is bitemporal hemianopia. You know this person needs surgery because the lesion, even if it is a benign, it will be slowly growing. It will be slowly growing, and the visual field is going to get more and more compromised. And if the visual field is completely gone, and you do surgery, it may not be reversible. Very important. So, only thing you need to remember in this situation is a prolactinoma. If you see somebody pituitary incidentaloma, visual field defect, but prolactin is 1000, so you know it is a macroprolactinoma. So we need to treat this medically, and within 2 to 3 days, 48 to 72 hours, we can document that the visual field has is already started improving. So you don't need immediate surgery, but all other condition, the surgery, obviously debulking, so that the visual field compromise doesn't happen, will be the rule of thumb.
Okay, thank you so much, sir. I hope you did justice with the answer. Sir, so with all your permission, I'm going to conclude this session, sir.
Thank you very much for
Okay,
listening
sir.
me.
Yeah. Sir, on behalf of MedTalks and IGCP, I sincerely thanks Professor Dr. Arpandev Bhattacharya for sharing his valuable expertise with us today. And thank you all to attendees for joining this CME session. Stay connected with MedTalks for such knowledge sharing programs. So